we'll give you a little time, Mary, to catch up with a few questions, because it's great. There are a number of questions for us all to look at, which have been asked. And I'll now first ask Tanni to respond to some of the comments and questions. First, what I thought we could do, there's a couple of questions from MSPs. So we can maybe take one there, which is given at 6:59. Is there a case for legal legislation to make access to palliative care? Is there a case for legislation so that the government should provide palliative care? But I believe Australia's considered some things. Thank you, Tanni.
Thank you. The short answer is yes. Palliative care should not be a postcode lottery. We've, heard figures about how much money is saved in the Canadian system. I don't think that necessarily takes into account the impact on doctors, nurses, and everyone else, because there's a cost to be paid or a price to be paid somewhere along the line. Palliative care should not be a postcode lottery, and I think people assume that they have potentially better access to it than they do. I've lost both my parents. I'd say one had great access to palliative care and the other didn't. And I think that rather than sending me off in the direction of thinking we should have legislation for people to end their lives, it's made me more convinced that we actually need to have better end of life care to help support people. So we also have to recognise there's a cost to palliative care. But actually, I think, we're a rich nation, and how we choose to spend our money and how we spend our money is up for a huge amount of debate. I'm much more in favour of keeping people out of the NHS, through physical activity, through mental health, wellbeing, prevention rather than cure, and actually then the money that we have available being spent on better end of life care.
Thank you. So maybe legislation then for palliative care should come before, if you want, yes. And it should apply to very many more people. In fact, nearly 80-90% of people who do die, in fact. Thank you for that very clear statement there. Another question while you're still there, Tanni, from an MP. Campaigners for assisted suicide claim that opposition from disability groups can be overstated. Can you advise which groups are for and which against? So there's a thought that some groups are more for than others.
Yeah, I can send a list through, but organisations like Disability Rights UK, and there is no body that is run by disabled people that supports the assisted suicide legislation. So I mentioned briefly about some figures that are produced that suggest that over 80% of disabled people support this, but actually without understanding what their impairment is and the impact that it has on their daily life, then it's difficult to say. But, a lot of the cases that I work on with people who are at a higher level of impairment, where they've had their support cut. I've dealt with so many cases in the past 2 years where had their social care cut to 1 15-minute visit a day, and they're having to choose between food or going to the bathroom, then that makes your life intolerable. Now, I don't think that is acceptable in terms of how disabled people are treated. So I'm happy to send through the list that I have, but it's that there is no group of people no group that's run by disabled people that supports this. And I think, because of my experience as a disabled person, I've had great care. I really have. But, I've also had people making massive assumptions about my life and about my quality of life. We had it in a debate recently where somebody said, well, and this has been raised by lots of different people in lots of different ways, but they personally, or different individuals, find being incontinent unbearable. It's like, well, I'm incontinent. I have to catheterize. If I don't catheterize myself, I wet myself. I have to use suppositories. Apologies for being really graphic about this, but this is the kind of debate where I think we should have this discussion. So it's a lot of these things we manage, and the view of what is intolerable is obviously different for other people. My experience as wheelchair use is generally positive. Not everyone feels like that about it. But if you're constantly told your life is intolerable, then it's very easy to believe it.
Thank you. And just I'll mention that transcripts of the webinar will be available in about 48 hours. One or two people asking about that for the to get the data that both of you have been presenting. So thanks for that. I'll maybe go straight to the first question that came in there because it is a broad one. What does the panel think about the safeguards that Liam MacArthur is proposing in the bill? And the Word document is in the chat. I don't think most people can see that there, but you may be able to. Any comments on the safeguards from the bill? Mary, would you like to come in and comment on that?
Thank you, Scott. Like any area in life, we try our best with safeguards. And what I would say is from the data that I've shown you, you can see that in Oregon, you can see that the safeguards that were carefully thought out in Oregon, in Canada, in Belgium, they've just not worked. And I think this is an area of great difficulty that would need very much more thought and consideration. And, you know, it has been said in an area such as assisted dying, it may be nigh impossible actually to have adequate safeguards. I don't know what Tanni thinks.
Thank you.
Yeah, I've spent a lot of time looking at safeguards, and if you look at the list, it all looks eminently sensible in terms of the cooling off period. I've covered some of the responses in my presentation, but actually, you know, how much money is going to be spent doing the assessment? You know, coercion is very rarely very direct and obvious to other people. You know, it's the little drip feed. So the, you know, suggestion where the person signs the declaration, you know, that is very easy to be coercive over. The one that I have probably most concern about, which is the person must administer the life-ending medication themselves. It comes back to what I was talking about in terms of the drugs. They're not easy to take. And the question is, what happens if someone goes wrong? Because something goes wrong, because it then conflicts with the statement about no one should step in. So what if someone's choking? I guess the normal reaction if somebody's choking is for the medical person around to prevent them choking. Then actually that would potentially be stopping them end their life. So do you let someone suffer even more when they're taking the life-ending drugs? And that's a question that we haven't debated in Westminster, and it's very messy and it's very difficult. But that is something that is really serious, because you wouldn't want somebody to be in more pain and suffer more because of what are supposedly the safeguards. So I just think it is really, really difficult to put anything in place that's that protects people. And I mentioned domestic. I work on domestic abuse legislation. You know, we see with that the amount of abuse and the amount of coercion that takes place, you know, in that situation, let alone getting into talking about ending somebody's life, I think is just too big a price to pay.
Thank you, Tammy. Yes, and I know that you wrote 400 words in the Times, I think, yesterday, and you mentioned these issues there. How about a right for something? Yeah, might end up, let's say, that someone feels they have to go ahead with this. Yes. So, and there are many, a number of safeguards that are listed there, such as 2 doctors doing it. But one issue is that the terminal care definition that's being adopted just now is a very broad concept of terminal care that was defined and changed quite recently, so that people could get earlier palliative care. And so this is anyone who might benefit from not late but early palliative care then are immediately possible. So it's really a call. We did that research actually, so people could get earlier palliative care, and now that's being used as a trigger for this. So that's just something that sort of is a point there, but there are indeed many safeguards. Mary, there's 1 or 2 questions about what is palliative care. I mean, could you just maybe answer is it just generalist or specialist? Just maybe mention that briefly, thanks.
Okay. Well, I mean, the formal definition of palliative care is really based on the whole person. You know, it's holistic care. It involves management of symptoms, but also psychological, social stressors, financial stressors, and importantly, also care of the family. So it's that holistic approach. The vast majority of palliative care is actually provided by non-palliative care specialists. The vast majority of palliative care is provided by general practitioners. And also other interested people, many respiratory clinicians, some cardiologists, many neurologists would be involved in the delivery of palliative care. Mm-hmm. And then, of course, the specialist palliative care that's traditionally been more involved in cancer care, but clearly that's been problematic and, have tried to move into other illnesses. So it's a broad term, and it doesn't mean terminal care. It doesn't mean end of life care. And one of the problems in the UK is because of the lack of resources, palliative care is often kept for the last weeks and days of life. And as Scott's alluded to, and his work demonstrates very clearly, palliative care, to really make an impact and make a difference to a patient, it should be introduced much earlier when the patient needs it, rather than waiting until those final moments.
Yes.
And this is something that the UK really has to deal with. I noticed there was a few questions around that, Scott, in the Q&A box.
Yes.
And I think that is a critical part of the whole conversation just now. What care are we actually delivering to patients and their families, and when are we delivering it? This is not an argument that's separated from assisted dying, because you see the relationship very clearly in all the data that we've described this evening.
Thank you, Mary. Yes, indeed, in Scotland, recently, a person is terminally ill if a registered medical practitioner has diagnosed them as having a progressive disease, which can reasonably be expected to cause their death. So many people with a serious illness would, if you want, qualify for that, or somebody would say, oh, yes, you have got a progressive, are you at risk of dying from it? Yes. And so that is an earlier definition so that people could benefit from the holistic approach that you mentioned, and care planning can start. It's not the time, I would suggest, to start on other issues. And it shows that so few people actually benefit from palliative care. Tanni, do you think those many people do not benefit from palliative care? Do you think then that would maybe they would lose the capacity to get a holistic care and to form a relationship with someone, and therefore feel that they would get support and lack of loneliness and address some of the issues that people have in seeking assisted dying?
Yeah, and sorry, just picking up on your previous point, there are many conditions that disabled people have that could fit into a much broader definition of palliative care. Having a discussion with a friend of mine who has MS, and the stage that they're at, they would very easily, if a law came in, would convince somebody that they would be, eligible for assisted dying. So as much as we're told it's not for disabled people, and Lord Falconer in one of his reports said, at this moment in time, kind of felt we're in the waiting room, that it's about opening the door. And then, disabled people are seen as a burden on society. They're seen as, compulsory do not attempt resuscitation orders were put on disabled people at the start of the pandemic. And I do understand the reasoning for it, but a lot of disabled people with no underlying health conditions had those do not attempt resuscitation orders put on them. Yes. And, that I would not want to be the doctor, making that decision. That is a really tough decision doctors were having to take about who to treat and how to treat. But that's just fed the fear that a lot of disabled people have about where they would fit into this. And sorry, your question on holistic approach. Yeah, I mean, we currently, disabled people don't necessarily have all their medical treatment joined up anyway. And that can be, if you've got multiple conditions, that can be quite difficult. So I don't think we join up treatment enough, and being able to spot things like loneliness, and where people are just looking for support in another way, is really important. I mean, assisted dying is a quick solution to a long-term problem, and there is no going back from it. You can't ask someone once they've gone through it, well, sorry, were you lonely? Did we misdiagnose you? Were you coerced? The whole point when you're asking questions about coercion, if someone's been coerced, they're going to say no. So, this is why the cost of actually doing a proper diagnosis could actually not really save any money. And do you know what? There's a part of me that says, as much as I really don't want a law change, if people want to do it to save the NHS money, be open and honest about it. Say that's why you're doing it. I'd rather that than wrapping it up in words of dignity and compassion, because a lot of people I know who are against changing the law believe in dignity and compassion as well.
Thank you. There was a question there about, should we bring in insurance plans for palliative care? My immediate reaction is no, because it should be part of core service, and even internationally, it's defined as something that people should get, a right, a human right, in fact. There's a question here about parliaments. Let me just take the one about the non-medical model for actually doing assisted suicide. Because many doctors, the BMA and others says, we would not want to get involved in this. Any thoughts on a non-medical model there? Because many doctors feel that this is going against their belief systems, really. Yes, and the practice. And there was another question there about trusts between doctors and patients. Would it affect that? Could you maybe discuss that area? Thank you.
Yeah. Thank you, Scott. I could say something. I noticed that there were a few questions about the non-medical model, and a question stating that, albeit the majority of doctors may not want to take part in assisted dying, surely we could have a subgroup of specialists who manage this. If I could deal with that first, that is clearly not working in the Canadian model. It's not working at all, and it's leading to poorer care for the majority of patients, because it's impacting on all patients. You can't separate these things out within a healthcare system. And I think this then brings us to this area of a non-healthcare model. And a non-healthcare model would mean that at least there would still be the time required to have the discussions with patients and the passing and exchange of information with the non-healthcare model, but it would impact less than the healthcare model, to be honest, in the care of all patients. And I think that's why many clinicians feel that if there is agreement that assisted dying would move forward, then they would very much favour a non-healthcare model, because of all the evidence that we see from other countries. And the only country that actually has continuing improvement in palliative care, which I don't think any of us would deny we need, the only country is Switzerland, that doesn't have this healthcare model of assisted dying. So I think that's something that, if the government decides to move forward with this, they have to seriously consider, A, what's currently happening with palliative and supportive care in the UK, and we know the answer to that, the situation of the majority of clinicians that I think, we have to listen to, and the evidence from other countries of the impact on palliative care and the care of all patients throughout illnesses, if you actually have a medical model of assisted dying. So I think these are big, important questions that would merit further thought.
Thank you.
I think what you said about the subgroups really interesting. and apologies, I always kind of start thinking about all the problems that comes with it. So what would what would worry me about that is doctor shopping, or somebody like Shipman, who would be much easier for someone who had intentions to get rid of people to sort of hide within that. And I think about trust. So I know there's a question about, disabled people trusting, and I've been having a look at some studies, and there's not huge numbers of studies about whether it would change the relationship between a patient and their doctor. The data that I've read is quite variable on it, but from talking to I was going to say disabled people and non-disabled people, they do tell me that worried about it would change their relationship, and whether they would be able to have a conversation about palliative care and end of life, or whether they'd be able to discuss some things with them that they currently would. So I'd be really interested, and again, I've had a quick look of information on the impact on doctors of doing it. And I've read data that shows that, doctors are worried about turning it down. They're worried about the impact on the individual. There's one article I read where it said, some doctors have comfort in providing assisted dying, but it doesn't really define what comfort is. So I don't think some of that data is available in the right way. And apologies for the bells going off in the background, having votes on the nationality and borders bill as we're speaking. So yeah, I just think this is why we don't have any easy sound bites within this debate, because there are so many different nuances to it, which affect the situation and affects the conversations that people could have with their doctors.
Thank you. Maria, a question from myself, really. The forward of the bill suggests that it's for people who have reached the limits of palliative care and face a bad death. That's the need for this intervention-assisted suicide. For people where palliative care fails, people, where you and I have failed, is that your experience, that many such people, you think, feel that they need this intervention at that stage?
I mean, my practice for the last 25 years has been based on challenging, difficult to manage problems in palliative and supportive care. That's what I do all the time, the tertiary referral. And I would say that twice in that time, I've had patients who have said that they feel unbalanced, that's what they would want, but actually both patients have changed their minds. So I don't think that is really the situation. I think it's more the evidence shows that it's patients often who are worried about control, are worried about the lack of control. They're worried about being a burden, particularly on family and, other social and societal issues. And we could quote lots of pieces of evidence. We could look at the data from Oregon, such as it is, and look at the vulnerable groups, the single males, for example, who were more likely to request euthanasia. It's a very, very complex area, but I can tell you it's not the patients who have the difficult symptoms who are most likely to request this. And we see that, in fact, from Canada, from Belgium and from Oregon, that actually it was a tiny number of patients who had actually seen a palliative care clinician, and presumably, at least at the time of assessment for euthanasia or assisted dying, hopefully they were at least offered that if it were a symptom issue. But that, of course, is a big hope, because it would seem that they probably weren't quite there. Let Tanni speak.
No, I was just agreeing with it, because I think there's a big difference. One of the things in the safeguards is that you're given your options. Well, you could be told that there's palliative care, or you could be told there's a hospice, but if there's not the funding for it, it's not a real option. So then that's more, I think, make you more likely to say, okay, if I'm not going to get access to this, then I would pick this as an option. So again, it comes back to will there be the funding available to make sure that this happens?
Yes, and access to palliative care approach it will be through primary care and hospitals, really, because the best will in the world, specialists won't be available for so many people. So it's the approach, being alongside and treating people's all the different aspects. What's the main issue? Is it loneliness? Is it an existential issue? Is it actually pain? And trying to support there, which dimension of need the itches, and trying to be with them and forming a support. That type of relationship we feel people would benefit from. And my experience is the same as a general practitioner in practice for 30 years in a practice looking after such people, very few, if any. But I had some examples, graphic examples of one young lady. It was a lady who said, "I'm being put out of my house. My sons are wanting the house," and it was so tragic. It was so sad. And it's when you said, where there's a will, there's a relative. These types of things, and it was just, it can be so tragic to see the nature of people. Sometimes there's good people and there's people who aren't quite so good, and people can be taken advantage of, quite rightly there. Mm-hmm. Any other questions you'd like to mention specifically? We've got another maybe just 5-10 minutes if we'd like that. Right, others there coming in with many questions. It's great, some of the same things there. Mm-hmm.
I was going to add something to the question on the citizens' jury.
Right, thank you.
And I gave evidence to that. I think citizens' juries can be very positive, but I think you have to have a clear understanding of people's views going into it, their personal views, and making sure that it's very balanced. So in the evidence that I gave, I had very little, handful of questions that I was asked about my opinion. A couple of people made it very clear that they were very much in favour of assisted dying. And I think, you need people with opinions, and you need people who are undecided. So I think it's just very important to get balance. And that's true if you had a select committee in Parliament or through the Scottish Government. Consultative groups have to be really balanced and bring people in with different viewpoints to challenge, rather than it being set up. So I was disappointed in the amount of questions that I was asked by the citizens' jury in terms of justifying my opinion. It felt more tokenistic that I was asked to appear than actually really wanting to listen to my viewpoint on the issues.
Mm-hmm. Thank you.
And I would agree. I think the citizens' jury is not the perfect way forward or the solution. But I've noticed that one of my colleagues, Rachel Kemp, has in the questions said, how can we get the facts out there? How can we get the information? Because, one becomes very worried that the most vulnerable people in society are those that actually are least likely to have the information about what's actually going on, even what assisted dying is, and also all the facts about general care and supportive and palliative care throughout an illness. And I think Rachel's point is very well made. We're clearly not getting the information out there. The polls show us that when assisted dying, 10% of people thought it was hospice care, and another 40% thought it was, withdrawing life-prolonging treatments. There's a really, really worrying lack of understanding out there. And I think to get to the stage of, voting on a bill that a significant number of society do not understand is a very worrying situation. And I think also as a caring society, it's so worrying that we're not really exploring what's going on about provision of supportive and palliative care for those that need it at the time that they need it. I don't see how we can ignore that when we actually are talking about assisted dying. When we see from the evidence that the two are so closely linked. So I think there are a number of worries here, and we need to make sure that choices are informed choices, and that the real evidence is actually out there in a way that's easy to be understood by all people.
Yes, thank you, Mary. That's so true. I mean, there is a real branding issue, you could say, with palliative care. You know, no one asks me as a GP, well, I'd like to be referred to palliative care. No, but when I'd love someone to benefit from that approach, and I wrote an editorial in the BMJ, do we need rebranding? And the conclusion was, not really. We'd rather just support and educate and let people know, so that people might come. And actually, I mean, I sometimes say if palliative care were a tablet, you know, it would be tremendous, because it can get places others can't get to, and it's cheap with very few side effects. It's just getting that message, and maybe politicians can help us with this, really, to realise that this is good, and it's a low cost, high value care that will improve quality of life as well as other things. Whereas, you know, assisted dying sounds, you know, that's good to die. Assisted suicide, maybe not quite so good. Maybe that's why it's not being called, really. And I know a lot of the people were saying we should actually call it what it describes it. And so maybe this branding could be an issue.
Yeah, I also think there's an issue that in the and surveys, you know, and I've quoted lots of them tonight, but when the first set of questions is framed around, do you want a good death or a bad death? Well, everyone's going to say a good death, aren't they? You kind of imagine they would. And then it's like, well, how do you think you can get a good death? And do you then agree with assisted suicide? People are more likely to say yes. Or assisted dying, because assisted dying sounds nicer. Assisted dying sounds like the Holyrood death, where you get a needle and you slip away. You know, a bit like anyone who's had general anaesthetic, which I've had a few in my time. Then when you start explaining to people, and this is the bit where there's no soundbite, that actually it's not an injection, and it might not be quite of a time of your choosing, it might not be in a lovely cottage in the hills somewhere, and you then start explaining about what it might be. The support for assisted suicide drops quite rapidly when people start understanding the, you know, what goes on behind it, and then the fact that actually you might not slip away, might, you know, we've talked a lot about the complications tonight. So I think there is something in the campaigners have been really smart with their choice of words by calling it medicine is good for you, you know, drugs are bad for you. So, you know, there is something in the words that we're using, and I don't deliberately, you know, try to be antagonistic with my choice of words, but I think we have to have much greater clarity on the words that we're using, and much greater clarity on the reality that it's not this Holyrood death.
Thank you. Yes. Question someone's asking, what actually is a non-medical model? And I think what that means is taken away from routine clinical care on the NHS or even privately into a different system, part of a wider death system, I suppose. That was what it would be. And a lot of doctors would say we would want to have nothing to do with this. But it gets that the safeguards again. We could talk more about that, but just the first one: 2 doctors independently confirm the person is terminally ill. Well, such a broad definition, and we know that in places like Holland, you know, if one doctor, the second doctor thinks, I can't do this, they'll be off to see another person and another person to register. And it's been shown that in some countries, there's maybe 500 cases go forward, and there are some doctors who have signed off very many people. And I was sensitive to your comment about Harold Shipman. Do you think this would be a risk of having that type of approach? Tammy, would you go back to just explain what you meant by that a bit, please?
Yeah, so in terms of the Harold Shipman, if it's a small number of doctors who signed up for it, somebody who is a Harold Shipman type person,
caring,
you know, caring, wonderful, lots of family members said how just like lovely he was. This is sort of open book, because then, you know, it's unlikely that, you know, there would be the documentation, there wouldn't be the checks and balances on that type of person. And I'm just madly looking through my notes, because it was something I left out when I was speaking, and because I was sort of editing as I was going along. But in Oregon, the number of doctors who prescribe for the number of patients, and you know, it's actually not a large number of doctors, and
sure.
number of patients. So I'll try and find that as we're talking. The doctor shopping, will happen. We've all got cases, good and bad, but I had a friend who had a terminal diagnosis, was told she had 3 months, and she died 11 years later. There's all these cases. So the accuracy of prognosis we know is not easy.
I remember a carer of a dear, her husband, who she cared for a lot, said to me one day as a GP, if I had a gun, I'd shoot him. And she wasn't talking about anything like actually doing that, but just saying how much she cared. And he was trying to let me know, I think, that he was struggling about it, but she loved him to the end. And phrases can be so mistaken sometimes. Any other questions, Tammy, you'd like to mention that you've seen there?
Sorry, I'm still looking for my data that I've got. Yeah. I'll keep looking if that's okay. Apologies.
Yep.
I probably won't be able to find it now that I've. Oh, hang on. Nope. Sorry, I haven't found it yet. Keep going, and I'll come back to it.
Question about NHS reforms in England actually might be good for. There's opportunities for palliative care to be purchased, if you want, at regional level. And in Scotland, in fact, we've had our integrated joint boards, and it's been a great opportunity, we think, that for people to come together and to emphasize and actually start purchasing palliative care. But sadly, it never really worked.
I agree with you. And I think one of the problems about palliative care is that it's very easy to pay lip service to it. It's very easy to go for the top line, but actually there's very little in the way of policies that actually dissect out actually the care that patients need, the governance, how that's going to be delivered. And if you note, any palliative care policy documents, they're always very broad, and there's rarely any governance issues associated with it. And I think this is why we continue to have so many patients who don't actually have access. So it's, palliative care is holistic care, it's broad, it should be available when patients need it. It shouldn't be reserved for the end of life, and certainly not the last days of life. But actually, it's that nowhere is it described how patients will actually access this in a timely fashion. And I think it all comes down to the structure of the NHS and how we deliver care. And until we have a true integrated model, then patients are not going to have appropriate access to palliative care in a timely fashion. And that really requires a rethink, and that requires effort. And it will, of course, involve costs as well. But that's life. We either want to provide care and do it properly, or we don't, and we look at alternatives. And I think these are some fundamental facts that we have to face. And it would be wonderful if our politicians actually ran with this and looked at how we can really integrate palliative care and really provide it and not just pay lip service to it.
Yes, thank you, Mary. Yes, indeed. I know some of the lower and middle income countries, politicians there are actually advocating for this as core, which is quite amazing. We've only really just a minute left now. So Tammy, is there a final comment you'd like to make before we just wind up? Thanks.
We'll say it really quickly. I found my data. So Oregon officials in charge of formulating annual reports conceded, and I quote, "There's no way to know if additional deaths went unreported because Oregon DHS has no regulatory authority or resources to ensure compliance with the law." Oregon is held up as, the sort of the great place where this takes place. And in 2020, there were 6,191 physicians in Oregon, but just 142 physicians prescribed assisted suicide drugs for 370 patients.
Thank you. Yeah. Yeah, and again, the provision of palliative care would be associated with supporting, again, back to the NHS, the big social care problem just now would support that as well. So I would like to thank everyone for your contributions. Thanks so much. I'd like to thank the speakers for the contributions. Everyone who's been sending in the questions, that's great. And joining the seminar, really appreciated that. It's recorded, as folk have asked, and will be available on social media in 48 hours. There will be email links sent to everyone registered, and we hope to have a further webinar in the coming months. So it seems that assisted dying is not as simple as advocates would have us believe. But there is strong evidence that an early palliative care approach from diagnosis of a life-threatening illness does improve care and quality of life, and a better life, better dying, and better grieving. So with these words, I'd like to thank everyone, wishing you all the very best. Good night, and thank you for attending. Goodbye.